Hello, everyone. I'm Rona Kalinga with AMSECT. Thank you for joining us today for today's webinar hosted by Abbott. The title is Extracorporeal Membrane Oxygenation, Then and Now. If you have any questions during the webinar, please be sure to enter them into the Q&A on your screen. We will get started in just a moment.
Well, hello there, everyone. Welcome to our Abbott webcast here. Barb, Lavelle, Vincent, Jason, first four of several hundred to log on today's event. And I want to welcome all of you, just seeing Laura and Lynn, Sergio coming on board to our event. Great turnout for this presentation. We welcome all of you to this event. This is, and you're in the right place for this interactive call, Extracorporeal Membrane Oxygenation, ECMO, Then and Now. This discussion is going to be moderated by Dr. Robert Cormos. We'll turn things over to him in just a minute. He is the Division Vice President of Global Medical Affairs for Heart Failure at Abbott. We're glad to have his leadership on this program here today. And he's got two guests that are joining him. Let me introduce them to you. They are Dr. Robert Bartlett from the University of Michigan School of Medicine, based out of Ann Arbor, Michigan, and Dr. Joe Walsh. He is from St. Alphonsus in Boise, Idaho, joining us here today. Yeah, I'll give you a little more detail about their background in a moment, but I do want to begin with some housekeeping items for all of you attendees. You'll see at the bottom of your screen multiple application widgets that you can use. Those are resizable, they're movable, so please feel free to move them around and get the best out of your desktop space. If at any time during our event here you have questions for our panelists, you are encouraged to go ahead and submit those through the Q&A widget. We'll do our best to capture all of those questions. We'll probably get to a few of them during the event, but we do have a good amount of content that we want to share time with the doctors on sharing with you. So we'll get to some of those questions that we don't answer live on today's event. We will work to follow up with you after the presentation. Best viewing experience, I do recommend a wired internet connection if you still have one of those. Close down any other programs or browser sessions in the background, especially things that might have audio or video. Chrome is our preferred browser for the platform. You can find some additional answers to some common tech issues. That's in the Help widget. Again, you'll see that at the bottom of your screen. A quick refresh of your screen usually fixes most of those little issues. At the end of the call, we're going to have a brief survey to fill out. Appreciate your feedback on ways that we can continue to create and bring you quality programs in the future. As I mentioned, I wanted to go ahead and give you a little background on our speakers here today. I'm going to start with Dr. Robert Bartlett. He is a professor emeritus in the section of general surgery, division of acute care surgery. He continues to be active in the lab and in clinical research. Prior to becoming professor emeritus back on July 1st of 2005, Dr. Bartlett was the director of the Surgical Intensive Care Unit. He was the program director of the Surgical Critical Care Fellowship. He received his medical degree from the University of Michigan Medical School. That was in 1963. He spent time at Harvard Medical School during the late 60s through 70. He was faculty at the University of California, Irvine in the 70s through 80, and he began at the University of Michigan in 1980, where he continues. And again, we're glad to have his full range of knowledge and information to share with us here today. Dr. Joe Walsh is also on board. He'll be presenting during the second part of our event here today, a practicing interventional cardiologist and the director of the Structural Heart and ECMO program at St. Alphonsus Health System, again, up in Boise, Idaho. previously worked as director of the ECMO and the ECPR program for Sutter Health, which is a large integrated health system in the San Francisco Bay Area, where he helped establish a 4-hospital hub-and-spoke model for cardiogenic shock, performing many 50-plus ECMO procedures a year in the cath lab. He established Northern California's first ECPR program as well, linking EMS and county providers to those receiving hospitals, implementing, again, that successful ECPR program with a 55% survival to hospital discharge. Dr. Walsh, very passionate about ECMO as a fundamental tool in the cath lab to manage sick patients, cardiac arrest, and other catastrophic complications. Again, we've got a wealth of expertise from him that he will be sharing later on in our program. With that, what I want to do is, again, turn things over to now Bob Cormos, and he's going to get us started on our content here. And Bob, will just double check that mute. It's the phrase of the year. You're on mute still.
Yeah. So we'll Thank you, James. Thank you. Well, I just want everybody to understand what an exciting afternoon this is going to be. You know, we have, and I think James mentioned it, the word passion really describes these two individuals, because this field of ECMO therapy really does require that element because of the amount of time commitment and the attention to detail for patients. So today, we're going to cover the whole spectrum. We're going to talk about the history and the development of this therapy, and then we're going to move to where it's going. And for that, you know, Joe Walsh will talk about how he in interventional cardiology has been able to take this to the next level. So we're going to begin with Dr. Bartlett. I want to just make sure everyone understands that honoraria are provided to our speakers, and that the presentation represents the belief of the speaker and does not necessarily represent the views of Abbott. So I'm going to turn this over to Dr. Bartlett, and again, I'm really thrilled to have you with us today, Bob.
Thanks, Bob, and welcome to all the other participants. I'm very glad to participate in this. I'm just going to spend a few minutes telling you a bit about the history and how we got to where we are now, and then Dr. Walsh will tell you how to do it, why to do it, and when to do it, and what's coming next. So from my point of view, this started as a resident at the Boston Children's Hospital when the mortality for big-time cardiac operations was 50%, and we thought if we could keep those patients alive a few more days, they would be all right. But the reason they were dying was the heart-lung machine itself. So we learned to replace the artificial lung with a membrane type of artificial lung. And with that, we're able to maintain animals on bypass for as long as several days. I presume you cannot see my cursor on your slide. So this is Phil Drinker, who's an engineer from MIT. He and I built membrane oxygenators, and with that, we're able to maintain dogs for several days on bypass. There was one other lab, Ted Colabo at the NIH, who was working on it, and between the two of us, we learned that we could maintain extracorporeal circulation for days at a time. Part of that had to do with titrating the dose of heparin, so we learned that we could give a very small dose of heparin to avoid bleeding from the patient, but clotting in the device. So the first clinical case was in 1971 in Santa Barbara, California, a young man who had ARDS following a motorcycle accident, and he recovered after a couple of days on what we would now call ECMO support. Don Hill, cardiac surgeon from San Francisco, and his engineer colleague, Maury Bramson, did this patient, and that's the Bramson oxygenator you can see there in the foreground. Our first case that we did was a little boy with transposition of the great vessels. We had done a mustard operation. He was dying that afternoon, and we brought our device over from the lab and hooked him up. This is a picture of him here several months later, Christmas time, and he's now 40-some years old and doing well. In 1975, we as myself and Al Gazaniga, my surgical partner, we were asked to see this little girl who's a full-term newborn, as you can see, a nice healthy baby with profound respiratory failure, and we hooked up our ECMO machine to this little girl, and she ultimately recovered, and she became the first neonatal case, which turns out to be very important. When we were running ECMO in veno arterial mode, as we did in those children, this is how it looks. The cardiac surgeons will recognize just a stripped down heart-lung machine, but we cannulate the right atrium through the jugular vein, drain blood out, pump it through a membrane lung, and put it back into the patient, in this case, into the aorta through the carotid artery. So beginning in 1975, that was the first neonatal case, and all the growth of this technology grew in neonates for the next 10 or 15 years. The project moved to the University of Michigan in 1980 and has developed there, so there have been randomized trials, follow-up of patients. We taught other people how to do this, maintained a registry of cases, and that brings us up to the present time. In 1988, we contacted all those people that we had trained in how to do this and asked for their clinical experience, and there were 700 and some cases that we could study, so that was very helpful. We now knew what the risks were, what the results were, what the complications were, with a variety of centers participating. That led to the development of the Extracorporeal Life Support Organization in 1989, which remains the main source of information, education, data collection, and so on with regard to this technology. Today, there are some 800 centers around the world that are not only capable of, but good at ECMO support in patients of all ages and diagnoses. In 2009, two companies from Germany got interested in actually building an ECMO machine and building the access cannulas that would be necessary to do it in a lot of places. And that led to much simpler, much safer circuits so that any center could set up an ECMO program and could buy a device that would work. That made the whole technology much simpler, so it could be run by a single caregiver, the nurse in the ICU, simple vascular access, and we hope that the physiology would become obvious. At the same time, we developed veno-venous support. This involves draining blood from the right atrium, pumping it through a membrane lung, but then back into the right atrium. So the blood that's in the extracorporeal circuit is all on the venous side. So veno-venous access requires good cardiac function in order to function. We measure the things that are listed in these boxes and calculate the important physiologic variables and use that information to regulate the flow and the hemoglobin and the function of the membrane lung. Because we're putting the oxygenated blood back into the right atrium, there's still plenty of venous blood in the right atrium. So the resultant arterial blood, if there's no lung function, is going to have about an 85% saturation. So it takes some understanding of the physiology to realize that's really okay. With the new devices and the better understanding of physiology, we changed the management of ECMO patients from what's called ECMO 1 in this slide to ECMO 2, which we've been doing since about 2010. patients are awake and alert, breathing spontaneously, extubated, or perhaps with a tracheostomy off the ventilator. The ICU nurse can run the system most of the time. We learned it was a bad idea to try to recruit the lung, just wait for the lung to recover. And bleeding is still the most common problem, but now it's manageable rather than being a potentially fatal problem. These are the current data that are in the registry, and you can see we maintain the registry by age, neonate, pediatric, and adults, and by the primary indication, pulmonary or cardiac failure, including ECPR for patients in cardiac arrest. This audience will be only interested in the last category, adults, and you can see that there are about 25,000 respiratory support cases and about 25,000 cardiac support cases. And as you can see, the overall survival is 60 or 40 or 30%, depending on the primary diagnosis. Not as good as we would like, but these patients are all moribund patients who would otherwise be dead. So that's the current state of where this technology stands for results and outcome. These are the types of patients that are in the registry. And you can see in 1990, it was almost all newborn infants. And each year, the number of newborns is about the same. But as a percentage of all the patients in the registry, it goes down every year, so that now only about 5% of the ECMO patients are newborn infants with respiratory failure. The others are children with respiratory and cardiac failure and adults with respiratory and cardiac failure. As I mentioned, there was a major change in the technology about 2009. So you can see the adult cardiac cases have increased exponentially every year. Same as respiratory cases. And the same is true for adult respiratory cases. So they're now in the registry about 4,000 cases per year. We estimate that the registry covers about half to a third of all the ECMO patients done around the country. But those of you who are participating here, if you get into using ECMO for your patients, you'll definitely want to join ELSO, get your patients in the registry for one thing, and also take advantage of the educational materials. So where we are today is that we use this technology for cardiac support or support of the circulation, always in veno-arterial mode. We use it for respiratory failure, usually in veno-venous mode, and management of patients nowadays is these patients are alert and awake, sitting up in bed, often going to PT while they're recovering. When they reach the status of recovery, we can learn to wean them off. For cardiac support, that's only a couple of days. And for respiratory support, it might be a couple of months. And ECMO is run in each hospital by specialized caregivers, usually ICU nurses, perhaps perfusionists, perhaps respiratory therapists. The longest case on ECMO with recovery is this little girl here. Her name is Reese. She was treated by Chris Nelson, shown us in this picture, at Hopkins. And she was on ECMO for 605 days and ultimately recovered totally. We would not advise you to try to manage patients for a year and a half like they did in this little girl, although she had a very good outcome. But Dr. Walsh will talk a little bit about when to consider long enough and move on to either heart or lung transplantation. So that's where we stand now. And Dr. Walsh is going to tell you how to pick the patients, how to set up a team, and how to actually do this ECMO technology.
So thank you, Bob. This is a remarkable journey. Did you have any inkling of how big the expansion was going to be in 10, 15 years from when you began to start this whole therapy? I mean, did you imagine this happening?
Yes, of course we did. And of course, the audience should know that Bob Cormos was one of the originators of this technology when he was at Pittsburgh. So we all worked together on this, kind of a small group of people who were devoted to this technology. But once you see that you have a technology that could keep a patient alive who has no heart function and no lung function for days at a time, then it was obvious it's just a matter of expanding that to a variety of other patients. Happened to be very successful in the newborn, so it grew there at first, but now, of course, applies to any patient with profound cardiac failure or respiratory failure.
What do you perceive as the biggest change in technology over these last 20 years? What's been the thing that's impressed you the most?
Well, in the early days, as you remember, we used to put together the ECMO machine with stuff that was in the storage room of the operating room or something you built in your garage or other things. And but once companies and industry got involved with making very reproducible, very safe devices about 10 years ago, that made all the difference. And that accounted for the remarkable growth we see now. Anybody can buy an ECMO machine and hook it up and use it. The biggest challenge right now is people do that without really knowing what they're doing. So the challenge for the future is all education to make sure that people who undertake this technology know how to do it.
Yeah, yes, and I know you've been involved in this a lot, and certainly the vision to create ELSO has contributed a lot to that ability to assess outcomes and produce quality results from center to center. So my last question to you is, I know most crystal balls are foggy, but let's have you imagine for a second, what's the technology going to look like in 10 years? What do you think we're going to have in our hands to treat respiratory and cardiac collapse?
It's different for respiratory failure and cardiac failure. For cardiac failure, the major question is, how is this person's brain going to work? Because they're usually in profound cardiogenic shock when they go on. They're anesthetized and paralyzed. And the major question is, are they going to wake up after a day or two? And many do not. And in that case, they might be organ donors, but you should just turn it off. So ECMO for cardiac support is only needed for about a week before you either quit or move on to a VAD and transplantation. So the devices we're using now will be fine for that as long as we choose to do it. The other application of veno-arterial ECMO is going to be in other forms of circulatory failure, particularly septic shock. So I think in 10 years, patients who have septic shock will go on to ECMO to sort out what their problem is and how to fix it. For respiratory failure, as you will hear in Dr. Waltz's presentation, usually these patients are on for 3 or 4 weeks of time and usually recover, but we've now learned that they can be on for months of time and still recover without needing a lung transplant. So the devices for those patients are going to be implantable or wearable devices. The first one of those is on the market now, a company called Breathe that Bart Griffith put together. And so if they're not better after a week or so, they will go on to a wearable artificial lung, similar to a VAD, but then they'll get out of the ICU. They'll even get home waiting for lung recovery. And if the lung doesn't recover in months of time, then they'll go on to transplantation.
Interesting. Dr. Yiannopoulos, whom we all know as very proficient in this field, has asked an interesting question of you, Bob. During VV ECMO, is there reverse deoxygenation as the blood passes through hypoxic lung areas?
No, it's a very interesting question, but we, of course, would maintain that the alveoli, whatever alveoli there are at least full of air, 20% oxygen, or maybe 30% oxygen, something like that. So because of the admixture of the membrane lung blood in the right atrium, which is 100% saturated, and the venous blood, which is there, which is typically 70% saturated, the blood in the pulmonary artery is always going to be about 85% saturated. So there's no loss of oxygen as it goes through the lung.
Gotcha. Well, Bob, thank you so much for this perspective. Again, we're honored to have you with us today, and this has been a tremendous review of just the complex journey that you started and now takes us to the modern era. And for that, we're going to have Joe Walsh take over and give us his perspective, as you said, on how to treat patients as an interventional cardiologist and what he can bring to the table. So, Joe, I'll turn it over to you.
Great. Thanks, Bob. And thanks, Abbott, for hosting this. I think this type of educational platform is really important. And this is a great field. I'd like to say it's a real honor to present alongside Dr. Bartlett, who's a real pioneer in this field. And I'm just hopeful that I can share some of my experience in starting a cardiogenic shock program and an ECMO program and some of the lessons that we've learned. So we're here today to talk about ECMO then and now. I think it's important to remember that we're truly standing on the shoulders of giants here. And if you look on the picture here from 1954, this is OR2 at University of Minnesota, where Dimitri is currently residing. He's on the webinar. It's an honor to have him as well. This is Dr. Walt Lillehei performing the first cardiopulmonary bypass procedure on a 13-year-old named Greg Glidden, who had a VSD. And his ECMO machine was Greg Glidden's dad, Lyman. And Lyman was hooked up to Greg with beer hose and a milk pump. And they cannulated the baby and they fixed the VSD. So I think it's important to remember where we came from and to where we are now. And I think what's led us to where we are now is massive improvements in the technology that Dr. Bartlett alluded to. We've got magnetically levitated pumps now. We've got oxygenators like we've never seen before. We understand the physiology of ECMO better than we've understood before. And what I think is one of the biggest developments that's led to where we are with ECMO currently is the structural heart revolution. And that has facilitated relationships with cardiac surgeons and interventional cardiologists like we've never seen before. And it's facilitated really facile skills at large bore access and percutaneous large bore access that's allowed ECMO to really flourish. So moving forward, these are my disclosures. I'd like to start with a case. I think it's always good to start with a case, which reminds us why we're here in the first place, which is to help patients. And so this was a case that I think really illustrated a lot of the value to ECMO and having ECMO readily available in the cath lab. This happened a couple of years ago. This was a 70-year-old gentleman visiting from abroad who had a history of CHF and a murmur. He was brought to my hospital, which is Mills Peninsula Medical Center, and that was right across the street from SFO. He was febrile and altered, and he had diffuse ST depressions across his precordium. He came to the ER. He did not look well. He was ashen. He was writhing on the bed, and he was brought to the cath lab urgently for a possible posterior STEMI. We immediately performed a right heart catheterization, and the patient's hemodynamics were not good, but they weren't horrible. He was tachycardic and hypotensive. He was mildly hypoxemic on 6 liters nasal cannula, and his filling pressures were elevated with a low cardiac index. I performed a coronary angiogram, which demonstrated a kind of a moderate to severe lesion in the circumflex, but not really a culprit lesion per se. And he had a very heavily calcified aortic valve. It was clear that it was probably quite stenotic. When I crossed the valve, again, apologies for the shadowing here. This is me taking my picture with my iPhone. When I crossed the valve, what you can see here on top is severely depressed ST segments reflecting global ischemia. And after I pulled back from the left ventricle, the patient went into what's widely known and regarded as the aortic stenosis death spiral. This is a patient who develops hypotension and global ischemia, which kind of begets more hypotension. And anybody that's ever worked in a cath lab knows that these are the hardest patients to get back. These are the patients that once they go into cardiac arrest, you'll really never revive them without therapies like ECMO available. So we immediately activated our cardiogenic shock team, which I'll talk more about and the logistics of that. The patient was intubated, and within 3 minutes after onset of cardiac arrest, the patient was put on VA ECMO with a 25 French cannula in the venous side through his femoral vein and a 16 French cannula in his arterial vein and his common femoral artery. It was clear that the etiology of this was critical aortic stenosis. So after stabilizing the patient on VA ECMO, I was able to perform a successful balloon valvuloplasty, as you can see here on the left. And then for venting, for the purposes of venting, I performed a septostomy with the same Tyshak balloon. And it was readily apparent that once we stabilized the patient, restored his oxygenation, he had full restoration of his arterial waveform and had significant improvement. We transferred him to our local transplant center where he was decannulated on day 5 and underwent a TAVR and a PCI on day 9. He was back on a plane to his homeland 14 days after the inciting event. So I think this case really illustrates how important it is to have ECMO available in the cath lab. We've all managed patients like this, and I'm sure we've lost a couple of them. But when you've got ECMO readily available in the cath lab to manage the sickest patients, complications, anything that you may encounter, you can really get saves like this. And I can tell you, these are the most gratifying patients to take care of in clinic. But a lot of work's put into developing these programs and these systems. And I can tell you one of the interesting parts of this case is I had a very similar one about 2 or 3 years prior to this case, where a similar patient crashed on the table with aortic stenosis. And despite Impella or balloon valvuloplasty, I did not get them back. So I do think that in cases like this, ECMO is probably the best option for these patients. So now I'd like to delve into the meat of the talk here. I really wanted to present a systematic method of getting ECMO into a cath lab and building a successful cardiogenic shock team. And I think when you're bringing ECMO into a cath lab, you have to do it under the umbrella of building a cardiogenic shock team. And that's a system that requires buy-in, not just from the cath lab and the interventional cardiologist, but from the ICU leadership, from the nursing leadership, and from your advanced heart failure colleagues. So it's football season. We got the playoffs coming up on Saturday. So I'm going to use a football analogy here. So the first step of doing this is to build a cardiogenic shock team and to have an algorithm, both an internal and an external algorithm. So this is essentially recruiting your players and building a playbook. And so I think this is the first and the most important part of building a cardiogenic shock team and bringing ECMO into the cath lab. We've got a great scientific statement from the American Heart Association that outlines best practices on establishing a cardiogenic shock program and building a hub and spoke model for managing patients with cardiogenic shock. And one thing that's clear from their scientific statement and from the data that's been borne out thus far is if you look here in a multivariate model stratified by annual hospital volume of cardiogenic shock, it's clear that hospitals that manage more cardiogenic shock patients have much better outcomes. The mortality benefit here was an absolute benefit of 5% when you compare the highest volume center to the lowest volume center. And so really the takeaway is do whatever you can to centralize your management of these patients at your hub center and work very closely with your spoke centers to identify cardiogenic shock early and get these patients transferred in a timely manner where they can be taken care of at your hub center. So who is the cardiogenic shock team? Well, it starts with the STEMI team. And I would argue that there's no team more ideal for the management of these patients than the STEMI team. They're already familiar with the tools in the toolbox. They've already got a rapport with each other and work well as a team in high stress situations. And there's already a mechanism in place to activate them in a timely manner. But the STEMI team is not nearly enough to manage these sick and dying patients. You need more personnel, you need more ancillary staff because there's a higher demand. The echo technician is a very critical part of the cardiogenic shock team, not just for the early identification of mechanical complications or valvular abnormalities like I showed in my first case, but also to facilitate various venting strategies and facilitate some of the treatment modalities that may be needed for these cardiogenic shock patients. The perfusionist is also a critical member of this team. I know we have several perfusionists on the call today. They are a critical part of establishing the cardiogenic shock team, but they can't always be the rate-limiting step. It's critical that, especially in an emergency situation, the cath lab staff be trained to implement the ECMO circuit and put the patient on before the perfusionist arrives. Now, that may not happen in the first couple cases, but if you wait for the perfusionist for the first couple cases and have them walk through those steps with the STEMI team and your cath lab staff, I find that to be the best way to get everyone familiar and comfortable with the system. Lastly, anesthesia. There's a lot of things we do in the cath lab that I find it hard to believe we do without the assistance of anesthesia. Managing sick patients, managing hemodynamics, even sometimes managing our own airways. This is not one of those cases where you can be doing that. These are the cases where you really need your anesthesia colleagues to come in to manage the airway, to manage vasopressors, and to assist with some of the sedation needs that these patients may have. So these are really the core players, if you will, of the cardiogenic shock team. And prior to implementing a cardiogenic shock team and an ECMO program, you really need to get all these folks on the same page, get buy-in from these folks, and invite them to be part of the team. The next thing you have to do once you've identified your players is build your playbook. And so that really starts with developing an algorithm. So when I think of algorithms for cardiogenic shock, I think of them in two different fashions. You've got your internal algorithm for the management of these patients in the cath lab, and then you've got your external algorithm for your referring doctors in the ICU and the emergency departments who will be sending you these patients. And so for the external algorithm, this is the example we've implemented at St. Alphonsus here. It has to be first and foremost simple, and it has to be easily translatable for emergency room doctors and ICU doctors. These are physicians that have a lot on their plate. They've got a lot of sick patients, so we have to make it simple for them, and we have to make it easy for them to activate the team. And in raising awareness with this algorithm, you're also facilitating relationships. And most importantly, you're facilitating early identification of these patients, because the longer these patients sit in the ICU with undiagnosed cardiogenic shock, we know the poorer their outcomes will be. And I can guarantee you across the country, all over, there's patients sitting in ICUs with cardiogenic shock that's not being identified. So this is a very critical step. So our algorithm is very simple: a systolic blood pressure less than 90 for 30 minutes, or a low blood pressure requiring vasopressors for support, in the presence of end organ hypoperfusion and some objective marker of reduced cardiac function. And so we've worked very hard with our emergency rooms and our ICU doctors to facilitate use of bedside ultrasound to identify left ventricular systolic function, as well as early use of mixed venous O2 from either the IJ or whatever line they may have in to identify patients with a low cardiac output. Once these patients are identified, you make it as simple as possible for them to contact the on-call interventional cardiologist, who will be the gatekeeper for the cardiogenic shock program. Once the patient arrives to the cath lab, it's important to have a playbook for how to manage these patients. And I don't believe that you can really subscribe a playbook across every cath lab in the country. Everyone's got different tools in their toolbox. Everyone's got different skill sets. So it's important to build your own internal cardiogenic shock algorithm with buy-in from all the interventional cardiologists and the cath lab team so that everyone's involved in the process. So this is just a simple demonstration of an algorithm that we've implemented at our center here at St. Alphonsus. Obtaining femoral access. I'm a big radial fan, but for these patients, you need femoral access. Performing early right heart catheterization, angiography, and left ventricular end diastolic pressure measurement. And then looking at their left and right-sided function to determine the optimal means of hemodynamic support. So on all the way to the left side, you've got adequate left and right-sided support. Use whatever you need. Then you've got poor left ventricular function, where you can either use an Impella, any other temporary LVAD, or ECMO. In my experience, if their cardiac index is in the low ones, generally Impella is not going to be enough, and those are patients you usually have to escalate to ECMO. Patients with left and right-sided failure need VA ECMO straight up immediately. And if they have hypoxemia or cardiac arrest, those are patients that should go straight to VA ECMO as well. And then lastly, for patients with isolated right-sided disease, which is not very common, you can use an Impella RP or you can use ECMO straight away. Importantly to note here, we also have a large set of exclusion criteria. The worst case scenario with ECMO is putting a patient on the circuit, not having an exit strategy, not having a way of facilitating the next steps. And that's where really being thoughtful about having exclusion criteria for these patients is critical. The next step after you've established your players and built your playbook is really kind of delegating who your coach is going to be, who are going to be the champions for your program. And it's not enough to have an interventional cardiologist as your champion for your ECMO program. You need a nurse coordinator or a nurse to facilitate interaction with the ICU staff, with the cath lab staff, and to coordinate the overall program. You also need a champion in the C-suite to assist with the initial purchase order and to really get the word out on your program and to assist with some of the administrative tasks. And in conjunction with identifying these champions, you really have to establish privileging and training for your interventional cardiologists. Now, I mentioned this early because this can take a while at some centers. I know at my center, it took about 3 months before we could get the initial privileging documents in. So this is just an example. It's not too onerous in terms of the requirements. It basically requires a half-day training course and an initial ECMO privileging of one procedure. And obviously, it may take a couple more procedures to get facile with this, but that's where you have the interventional cardiology champion that can come in and assist with interventional cardiologists who may not be comfortable doing this or using large bore access. This is also important to really build a framework around competency for ECMO, because as the program grows, it's important to establish that so you can establish best practices in your hospital.
So, Joe, this is a great start. I think you've covered some really important issues. We have a question actually that came out of the audience, which is, how do you involve the surgeons in the decision making once somebody's on ECMO? What role do they play? And then a question that's a derivative of that question is, if a cath lab team is interested in doing this and the surgical teams already run ECMO, how do you form that synergy to actually get the cath lab involved in partner and get going with this therapy?
Oh yeah, those are great questions, and this is very pertinent to 2020. And as I alluded to in the introductory slide, I think one of the things that's allowed ECMO programs and cardiogenic shock programs to really grow and develop is the relationship that's evolved between the cardiac surgeons and the interventional cardiologists through structural heart. And so I would encourage any interventional cardiologist thinking about starting an ECMO program to work with their cardiac surgeons who ultimately know more than we do about this technology and have used it for a much longer time. Most of what I know about ECMO comes from my cardiac surgeon, Brett Sheridan, who I worked with in the Bay Area. So I would encourage anybody to work with their cardiac surgeons. At my last institution, the cardiac surgeons took ECMO call with us as part of the circulating call schedule for the cardiogenic shock team. So the reality, however, is that cardiac surgeons don't always have the bandwidth to manage these patients and are not always the front line of seeing these patients. We know that 5 to 10% of our STEMI patients are going to have cardiogenic shock. So I would say that we're ideally suited as the front line of defense as interventional cardiologists to manage these patients and to put them on hemodynamic support earlier rather than waiting for our cardiac surgeon colleagues to come in and put them on. So I think it's really a team approach. And in my experience talking to others who have started programs, they've had nothing but support from their cardiac surgical colleagues to manage these patients and take them on.
Yeah. And another quick question on this, in this area is to maintain proficiency and to train more physicians that will then feel comfortable doing what you've learned to do very well. How do you maintain that training, and what things are necessary to establish the training program?
Yeah, that's a great question. Again, I think the most critical part of the training piece of this is being comfortable with large bore access. And I think structural heart, Impella, these are things that have allowed us to get more comfortable and more facile with large bore access. So in our training program, we really emphasize the fundamentals of high quality best practices for large bore access, which include ultrasound guidance on every case, even if the patient is getting ECPR and there's chest compressions going, taking that extra couple minutes to get the ultrasound machine to really identify that vessel and see the needle go in is critical. So that being facile with various wires and dilators to facilitate the cannulation, and being facile with pre-closure and post-closure of these cannulas. I think those are the most important part. I think the physiology kind of takes care of itself. Once you've managed a couple of these patients, you understand a little better. And again, whenever I have questions about ECMO or some of the nuances, I always query my cardiac surgeons, because I find them to be extremely helpful, and my perfusionist colleagues. So it's really a multidisciplinary thing, but from an interventional cardiology perspective, the learning curve primarily lies with the large bore access skills, in my opinion. So
Perfect. I'll let you continue, and I'll leave any questions to the end because of time. I'll just let you continue. But thank you so much for answering those questions.
Oh yeah, for sure. So we've established the players, we've built the playbook, we've got our kind of coaching staff and our champions. Now we have to buy the equipment and assemble the cart. And this can be where it gets a little bit tricky in terms of understanding the nuances of moving forward with this. So when you want to get ECMO, you have to build the case, and you're not only building the case with your administrators to make the initial purchase, you're building the case with your nursing staff, with your cath lab. When you start trying to encourage your cath lab to do ECMO, the first thing you're going to hear is we're not perfusionists, that this is not under the scope of our work. And to some degree that's true, but what I always try to bring it back to is the patient, that this is an essential tool to manage the patients we see every day in the cath lab. And I would almost argue that it's unethical to do high-risk, complex cases in a cath lab when you don't have ECMO available. And so really emphasizing ECMO as the ultimate parachute in a cath lab that's doing high-risk cases is the first step. Then you need to talk about the actual steps of going on to the ECMO circuit, which in my opinion is much easier than an Impella, rotational atherectomy, a lot of the other things that we use in the cath lab. This is actually much simpler to start. Now, granted, there are much more nuances to it once you have a patient on long-term, but for the initial 30 minutes of cannulation and putting the patient on circuit, I would argue that it's simpler than a lot of the other things we do in the cath lab. The other thing to say is this is full support. We don't have to worry about oxygenation. We don't have to worry about RV function. This is something we need in the cath lab. And lastly, and probably the easiest part of convincing and building the case at your hospital is it pays for itself. It's an extremely well reimbursed procedure. And there's some other economic things to understand about it that I'll talk about in a couple slides to really sell your administrators on making the initial purchase order and building the case for an ECMO program within your cardiogenic shock initiative. This is a picture of a Cirrus airplane. This is one of the only airplanes with its own parachute. And this is basically how I think of ECMO. It's like flying a plane with its own parachute. And so whenever you're doing cases in the cath lab that are high risk, having this available makes me much more at ease knowing I can crash onto this if the patient doesn't do well. So I think this is a good analogy when you're trying to build the case and explain why you need this in your cath lab. This is the DRG for Idaho. And again, this is $124,000 every time you put a patient on ECMO. This is actually much lower. In the Bay Area, it was around $200,000. And explaining this to your administrators that this is a highly reimbursed procedure with a very high net contribution margin if done appropriately, that's really all you need to say. The first couple ECMO cases may even pay for themselves. And the other thing to know about ECMO, which I learned from my surgeon, Brett Sheridan, is that when you have a high number of ECMO cases at your hospital, you not only get the contribution margin for each one of those cases, you're significantly increasing what's called the case mix index of your patients in your hospital, which is basically a metric that reflects the overall sickness of the patients you take care of. So when you do a lot of ECMO cases and your case mix index goes up, your hospital makes more money on every single patient that they're treating, not just your ECMO patients. All Medicare reimbursement goes up. So it's an extremely profitable procedure. And in my opinion, it's a win-win-win in that the patient wins because they have a therapy that saves their life. You win because you're doing something that's gratifying and saving the patient's life, and the hospital wins. So it's one of the few things I feel like it's left in interventional cardiology where everybody wins across the table. This is the core components of the initial purchase order. And I think it's important to understand what makes up the capital expenditure of investing in ECMO versus the replenishables. These are the things that'll be on your initial purchase order, which depending on the number of circuits you order can be anywhere from $100,000 to $500,000, depending on everything. So it's important to really know what you're getting when you make an initial purchase order with ECMO. So these are the components we use in the Bay Area of our CentraMag system. You've got the capital expenditure items, which include the console here, which I think of as basically the hard drive that displays all the important metrics like RPMs, pressures, et cetera. You've got the motor, which actually rotates the blood and connects to the pump. The pump is actually the interface between the motor and the blood. For the CentraMag, that's the magnetically levitated pump. It's actually basically a HeartMate 3. And then you've got the oxygenator that actually provides the oxygen into the blood. So these are the things that we call the replenishables, in that every time we put a patient on ECMO, we have to get a new purchase order for those. Whereas the console, the motor, and the cart are basically the capital expenditure items. So these will be the things you initially make an order. And I would encourage you, if you are going to invest and go into an ECMO program, to buy 3 or 4 circuits, because you're usually going to need a backup for the first circuit you put on. And then if another patient comes in that needs ECMO, you're going to need another one. So don't just buy one, try to get 3 or 4 with your initial purchase order if you can, because it makes it a lot easier when you're trying to scale a program. You've also got pressure transducers and various tubing. You've got your cannulas that you need to have every case. And then you've got your various dilators, access supplies, and wires, which I'll go into in a little more detail. I encourage anybody who's starting an ECMO program or a cardiogenic shock program to build a cart. You want one of those large mobile carts that we have in all the cath labs. You know, you got your Watchman cart, your TAVR cart. You should have an ECMO cart as well, because this is going to start in the cath lab, but I assure you it's going to very quickly move into the EP lab for VT ablations or crashing EP patients. And then it'll go into the ED or the ICU, maybe even the lobby of your hospital. But you're going to need a mobile cart to facilitate very quick cannulation of these patients with really all the equipment you could possibly need. So in terms of access supplies, I'm a big proponent of micropuncture for all these patients. You'll need a variety of stiff wires. Taper dilators are critical, and really high quality taper dilators. I really like the Kuhn's dilators made by Cook. Those are fantastic dilators for getting the cannulas in. I usually pre-close my artery and then use a Z-stitch for the vein when I close it. So that's Prolene. And then ultrasound covers. For cannulas, I would say 80% of my patients, and there's a lot of controversy on this, 80% of my patients, I use a 16 French arterial cannula and a 25 French venous cannula. And I found that the rate limiting step for achieving an adequate flow of 4 to 5 liters on most of these circuits is the venous cannula size. And so for a normal sized person, I'll generally use a 25 French venous cannula, and works very well for getting adequate flows. You're going to want to have a 5 French braided sheath for antegrade perfusion when that's necessary. I don't always do antegrade perfusion. I'll talk a little bit about that on one of my last slides. The important thing, though, is that it's braided, because if you put a non-braided sheath, especially in a large patient, the sheath will kink and you'll get bleeding around the SFA, which can be catastrophic, especially in a patient who's being therapeutically anticoagulated. So having the cannulas readily available. Tubing hookup supplies, so the turkey baster for a solid wet-to-wet connection, a variety of large clamps, and then things people tend to forget in their ECMO carts that are critical is male-to-male connectors for the antegrade perfusion cannula, and then sutures to sew in cannulas, because anyone who's done enough ECMO knows that if one of those cannulas come out, it can be a catastrophic, life-threatening event. So having a triple sutured cannula is critical.
And Dr. Kormos, it's James here. I'm just going to jump back in, confirming that you can still hear Dr. Walsh.
This is Bartlett. I cannot hear him.
Thank you, Dr. Bartlett, and that's what we thought
we can.
could have happened. So we have had just a little bit of a drop of his phone. So what we're going to do is try and get Dr. Walsh back on the line here. And Dr. Walsh, if you can hear me, what I'm going to tell you is that we cannot hear you, sir. So I'm going to try and see if I can unmute your line. And folks, it looks like he's still speaking there and he's unable to hear us. So I'm going to try one thing on the back end of our tool to see if I can force a reset of his line there with a mute unmute. So hang with me one second here. And Dr. Walsh, can you hear me at this point? All right. He cannot. He's continuing on there. Unfortunately, we're unable to reestablish with him. Looks like he's just resetting his line. So, Dr. Kormos, what that means is he'll be back in here in just a moment.
Can you guys hear me okay?
Yeah, now we've got you reestablished, Dr. Walsh. It was about a minute or so ago. We just had a little dropout, and then you continued on, and we had, but we were off for about a minute. So if you want to back up just a little bit there, you were really just getting into that section, the training of the staff.
Perfect. All right. So back to our football analogy. So it's training camp now. So we need to train everybody, get them comfortable with the circuit. And so, like I said, you want to leverage your perfusionists because they have probably the largest knowledge base of these circuits, the troubleshooting, and a very good understanding of how these circuits work. You also want to leverage your relationships with industry. They can oftentimes bring in a wet circuit to work with, and they've also got a very deep knowledge base in terms of working with these. So I just put on a training for the interventional cardiologists at my hospital. We had Abbott there. We had our nurse coordinator there. We had a wet circuit set up. We went over access and a lot of the troubleshooting. Having separate sessions for your cath lab and for your interventional cardiologist is critically important. The cath lab staff is going to need to get signed off and make sure everyone's comfortable with it before you move forward. And really, like I said, bringing it back to the patient and how critical this is for managing the sick patients we see in the cath lab every day is the most important part, and concentrating on the simplicity. Going an overview of the circuit and the components like I just showed you. Most importantly, how to hook up the cannulas in a safe manner and give heparinization as appropriate. How to turn up the RPMs until you get to your optimal flow level. And when you see chugging, which is usually a limitation of venous return, that's usually your max RPMs on the circuit. And lastly, the critically important concept of preload and afterload dependence with these ECMO circuits. Knowing that if the blood pressure is 180, once the pressors have a chance to circulate, will lower your flow rate is critically important. Knowing that if a patient's bleeding and your flow rates are down to 2 or 3 liters, that you have to give them adequate colloid or crystalloid resuscitation is important. And lastly, having one of those laminated checklists on the ECMO circuit going over all the steps is critically important. Another really important part once the training has been implemented is doing some cases. And you don't want the first case you're doing with ECMO to be a cardiac arrest patient who's crashing and burning, and everyone has a horrible experience. You want to do 3 to 5 cases of a complex PCI, of a VT ablation, of a patient who's got a slow slide into cardiogenic shock. Trying to plan a couple cases where you can get all of the staff in the room with the perfusionist to understand how to implement the circuit and troubleshoot some of the key things is critically important. Lastly, I'm going to go through, just because I know we're short on time, this is generally the checklist for ECMO before they leave the lab. These are the critical things to try to accomplish. You want to have the cannulas in safely and sewn in opposite legs. You're going to have a much lower risk of arterial ischemia and compartment syndrome if you have the cannulas in opposite legs. This is something I learned from Dr. Sheridan. If you have a 16 French cannula in the artery and a 25 French cannula in the same vein, none of that blood is going to have any outflow back to the heart from that leg. So you're going to run into problems with both ischemia and compartment syndrome. So really trying to separate the cannulas in opposite legs is important and can mitigate a lot of the risk of arterial ischemia. Everyone who leaves the cath lab on ECMO needs a Swan-Ganz catheter. One of the key metrics of understanding who can be weaned from ECMO is the ratio of the mean arterial pressure to the pulmonary pressure. So you really need the Swan to guide your exit strategy and your decannulation strategy. Everyone needs a right radial A-line. This is critically important in that the right radial A-line is the farthest point from the inlet of the arterial oxygenated blood. And it gives you a good sense of what the lungs are doing and what the heart is doing. An antegrade perfusion catheter is not something I put in everyone. I'll look at the size and caliber of the common femoral artery before I place the arterial sheath and make a decision based on that, as well as the flow in the SFA after the cannula is in. I'd say I probably put a perfusion catheter in about 50% of the patients that I treat with ECMO, but not everyone needs one. A Foley is critically important to understand their urine output and make sure they're getting adequate perfusion of their kidneys. And lastly, and probably most importantly, you want to have a venting strategy in place, whether it's a balloon pump, a septostomy, or an Impella, some strategy that everyone's comfortable and familiar with. And you want to have a dispo strategy in place before they leave the cath lab. It's talking to your advanced heart failure doctors. It's understanding, is this a patient that's going to go on to LVAD or transplant? That's one of the most critical parts of doing ECMO the right way. So with that, that's all the information I have, kind of a whirlwind tour here. But I'll welcome any questions if we have time.
Well, we're very close on time. I did want to ask you though, Joe, do you use oxygen sensors on the legs to measure O2 sat differentially?
Yeah, absolutely. We started doing that in the Bay Area right before I left, and we found it quite helpful. You know, I think it's one of those things like intubation where if you think of it, you should probably do it. And if you have any concern, you really want to do it because that is a big liability is arterial ischemia in ECMO patients. So I would have a lower threshold to put an antegrade perfusion catheter for most things.
Well, I think given the time, anyone that has questions, please forward it to us and we will make sure we get answers to you. But this has been a tremendous journey from both the inception of ECMO, the inception of understanding what data we need to collect and how we develop best practices to really understanding how to implement this therapy in the cath lab. And I think what you know, I heard through your presentation, Joe, how much you learned from the surgeons. And I think what really this brings to mind, and you can comment, is the close partnership that you feel is necessary to develop, because it is a multidisciplinary challenge, these very sick patients to manage them carefully.
Absolutely.
All right, so I'm going to turn, James, thank you both of you, Dr. Bartlett and Dr. Walsh, for taking time with us this afternoon. Thanks to the audience for being with us today. I know we had quite a large audience, and I hope this was helpful to everybody. James, it's back to you.
Well, thank you, sir. And let me call out to Samit and Joy, Shayef, Timothy, and many others. Questions that have come in, we will collect those on the back end. We'll get them over to the Abbott team, and if there's a way that we can get some responses from Drs. Bartlett or Walsh, we will do so. Also, we have our Abbott reps that can fill in some blanks as well and share some information. So we will do that. On behalf of the entire Abbott team, again, folks, thank you all for joining us. Huge thanks to Dr. Kormos for moderating the discussion, and of course, Dr. Bartlett and Dr. Walsh for taking time, joining us here, sharing their experiences and their expertise. As for all of you in attendance, again, a brief survey is going to come up at the end of this call. If you could fill that out, we would appreciate your feedback. Allows us to continue to look at these programs, make improvements where needed, and continue to bring you strong information in the future. So please do that. With that, we will wrap things up, and we do look forward to having you on more webinars in the future.
Thank you for joining us today. Just wanted to let you know that a recording of this webinar will be available in the next 48 hours on the AMSECT website, and you will have access to it for the next 6 months. I'm going to pass this off to our rep from Abbott.
Thanks, Rona. Hi, everyone. My name is Fiaz Mohammed. I'm a program manager in the heart failure professional education team at Abbott. And just wanted to thank you all for joining us on this webinar. This was a pre-recorded webinar from an earlier talk with Dr. Walsh and Dr. Bartlett. All the questions that were asked, Raymond, I know you threw a question in there. They will be forwarded to the speakers and responded via email. And as was previously said, this content will be available on demand for the next 6 months. So we appreciate your time and look forward to seeing you on future webinars. Thank you.